All right, everyone, we're going to go ahead and get started. It's a couple of minutes past the hour here, and we have a pretty jammed session. We have a didactic presentation from Laura Lander, who I see is on, and Laura, you are a co-host, so you'll be able to run your slides here in a minute. And then we also have a case presentation from Dr. Jennifer Price, and I don't see her on the Hollywood Squares yet, but we're going to do Laura's, oh, there she is, Laura's didactic first. So again, if you're just joining, with the number of people on the session, we're doing introductions through the chat. So please put your name, your email, your organization, and your credentials, and that'll serve as your intro, and then also CME purposes. And I do see a couple of rooms that have multiple people in there. If those people also are partaking in the session, please make sure to put their information in as well, because it will only record the one room. It won't record everybody that's in the room. But are there any questions before we get started? Okay, hearing none, we will get the show on the road. Laura, you are a co-host. Feel free to share your screen and get started.
Great, thanks, Jay. So for those of you who don't know me, I'm Laura Lander, I'm social work faculty in the Department of Behavioral Medicine and Psychiatry in Morgantown with WVU. And today we're going to talk about the treatment of pregnant women with stimulant use disorder. I think we had all gotten, or many of us had gotten proficient with working with pregnant women who had opioid use disorder, and then somewhere between regionally, depending on where you are, somewhere between 4 and 5 years ago, we saw a huge surge in women coming into treatment with substance use disorder, specifically stimulant use disorder, and very often women who were using methamphetamines. And it's a very different clinical picture, so that's what we're going to talk about today. All right, so I'm going to start my slides here. All right, everybody can see that?
Looks good.
Thanks. So we're going to go over the epidemiology and kind of the history of the evolution of methamphetamines in the United States, and then a little bit about the impact on pregnant mom, fetus, and early childhood, and really focus on the complex presentation that women and people with methamphetamine use and stimulant use disorder can have because of their precipitated psychosis that can co-occur. And then the evidence-based treatments. So many of you guys know there are no FDA-approved medications, so there's no medication assisted treatment for stimulant use disorder, but there are multiple evidence-based psychotherapies. So worldwide, there's about 40 to 60 million people who use methamphetamines, and it comes in various forms. It can be smoked or injected or inhaled. And it's kind of some pictures of the forms. And then amphetamines, in terms of the prescription amphetamine, comes in different forms as well. And people can crush that and use it in a variety of different ways as well. So major areas of use are listed there, and North America is certainly one of them. And it's, you know, there's been a history of, and I'm not going to go way back, but just recent history of waves of methamphetamine use in this country. So in the early 90s and 2000s, mostly methamphetamine was made from pseudoephedrine, which was decongestant found in Sudafed, and in like local small labs. And so Breaking Bad obviously shed a lot of light on that for those of you who've seen that series, but it was not on a huge scale. And then when Congress passed the Methamphetamine Act, it really reduced access to pseudoephedrine dramatically, which was initially wonderful. And we saw a decline in use of methamphetamines. However, then the Mexican drug cartels essentially learned how to make methamphetamines in a different way that didn't use pseudoephedrine, and it was actually higher potency and cheaper to make. And then we saw a big uptick in the surge of methamphetamine production and use that followed. And really in the last 5 years or so, again, it varies regionally a little bit, we have seen a huge surge in very low cost, pure methamphetamine. And what we saw, at least in the Morgantown area, was patients would come in saying, I can't find opioids, or I can't afford opioids, especially that people can't afford prescription pain medication and even heroin. And so the cheap alternative was methamphetamines. And even though it was not the substance they were seeking, they ended up using it and becoming addicted. And so we saw this really interesting and concerning shift. So just in 2018, they seized enormous amounts of methamphetamines on the border, and much cheaper and can be lethal as well. So you guys are maybe familiar with this slide. When we think of the different phases of this epidemic, this overdose epidemic, first we had prescribed opioids, and then the second wave we saw heroin come, and kind of see, in 2010 there began to be a surge of access to heroin and a lot of overdoses attributed to heroin. And then in 13, 14, fentanyl had a huge surge, and then stimulants, which included to a great degree methamphetamines, came right kind of alongside with the heroin. And often what we find in talking with people, especially people who present to the emergency room with an overdose, is they do not realize what they've used, and fentanyl and methamphetamines are often mixed together, which can also be a lethal combination. So this has really changed over the last 20 years. So when we think about pregnancy, methamphetamines and other stimulants affect pregnancy in very specific ways. So that kind of growth retardation can occur, increases in preterm labor, placental abruption, so the placenta actually peels away from the uterine wall, which obviously causes problems, some growth issues with regard to head circumference, and withdrawal can occur, so withdrawal from like any stimulant withdrawal the baby would struggle with. And then in terms of long-term effects, we see learning difficulties and some cognitive deficits. Whenever we look at long-term deficits and struggles, it's always very difficult to tease out what was specific to the intrauterine exposure and what may also be a result of environmental factors if the mom is continuing to use as the baby grows after it's been born. And then postpartum considerations. I mean, for those of you who know women or anyone really struggling with methamphetamine use, the idea of trying, I have children, and when I think of my years of dealing with small children, the idea of trying to deal with small children and struggling with a methamphetamine use problem is just like unfathomable. Like there's no way that I could have done that, because your sleep-wake cycle is completely disrupted, and your sleep-wake cycle is already disrupted if you have a newborn or young children. Very difficult, a lot of difficulty organizing thoughts and focus and staying on task. So that prefrontal cortex and all the executive functioning is often highly disrupted by methamphetamine use, and a lot of irritability, and then also psychosis. So parenting can be very, very challenging with a methamphetamine use disorder. We actually see among, say, women, the first wave in the earlier 2000s and middle 2000s, people could function okay with opioid use disorder when it was mild, and even into moderate, and it was a little bit of a longer progression. When people begin using methamphetamines, they typically progress to moderate or severe use very quickly. And so it can look different, and people become ill much more quickly. So we're going to look at symptoms, and this is really very different symptom presentation than, again, what many of us used to treat a lot of, which is opioid use disorder. So when we think about stimulant use disorder, and specifically methamphetamines, because people tend to, that just seems to be the stimulant that the majority of people are using in this region. We know that there are lower retention rates among women and people in general with methamphetamine use, and more frequent relapses. And in general, because of the route of administration and the chemical makeup of methamphetamines, this whole list of medical problems are much more common in a way that they're not as common in other kinds of substance use disorders. And so you have like a medically, potentially, especially if they're on the severe end of the use disorder, medically fragile person, and then you add pregnancy to that, and it just further complicates the picture. We also see a lot more cognitive deficits, and this does not have to be a result of like years and years and years of use. You see these cognitive deficits fairly early on because the progression can happen so quickly. So poor performance on motor processing skills, verbal issues, attentional issues, comprehension issues, all kinds of cognitive struggles. And then obviously behavioral issues with regard to impulse control, disinhibition. And what has been the most challenging for, I think, for healthcare providers, both in like the outpatient mental health setting as well as emergency departments, is the violence. I mean, we just did not see this level of violence with individuals with opioid use disorder. And so it's a terrible thing to feel afraid of our patient, and like how do you work with someone that you're afraid of, and that's why when we talk about treatment, it's really a stepwise treatment that's really important. Mental health problems, so higher comorbidity of psychiatric problems and more severe psychiatric problems like psychosis. So methamphetamine-induced psychosis is relatively common. And then case management needs. So people's lives fall apart severely as a consequence of this disorder. And so we see a lot higher rates of unemployment, homelessness, less social support, isolation. And so it's like this group of patients is often sicker. And with any stimulant use disorder, craving actually seems to be slightly different. And they've done, studies on this because stimulants release the highest levels of dopamine in the brain. The craving is experienced as more intense and overpowering. It's what patients will describe. And it's triggered by the usual things, people, places, and things, as well as emotional states. So that's not different than other substance use disorders, but the intensity can be greater. As a result of some of these cognitive deficits and behavioral issues, insight-oriented therapies appear to not be as helpful, and more behaviorally based, especially in the early phases of treatment, seem to work better. So the most important thing early on is really to manage acute intoxication and psychosis. It's very difficult to treat a violent, intoxicated, psychotic patient on an outpatient basis. I mean, it's like not safe. So inpatient is often really recommended. And sometimes that requires involuntary hospitalization if the patient is not able to voluntarily agree to go into the hospital. And that's always very stressful for providers, but often necessary. And then management of withdrawal, which can take 2 to 10 days, depending on frequency of use and intensity of use and duration. And those can be, some comfort meds in terms of helping patients with those withdrawal symptoms, since there is no long-term kind of medication-assisted treatment for stimulant use disorder. And then long-term behavioral treatment. So this is the list of the different evidence-based treatments for stimulant use disorder, which there are a few of, that's the good news. So once you get folks past the acute phase of detoxification, which may require inpatient medical support, thinking about these particular approaches. We're not going to go into these approaches in great detail because we don't have time for that, but I just want to do a quick overview of each one. And perhaps if you wanted to get further training or look into the models, that might be something worth doing. So you all have heard a lot about contingency management in the last year or two. There have been lots of trainings that have been free around the state that DHHR has supported, and we've tried to do some trainings here. But contingency management in general is really a systematic delivery of positive reinforcement. So it's a very behavioral intervention that we've actually incorporated into our comprehensive opioid addiction treatment program because we have so many women, pregnant women included, who are have comorbid opioid use disorder and stimulant use disorder, and so we've incorporated it there with great results. And the idea is because of the dopamine deficit, especially early on in recovery, this reward system actually helps produce dopamine for patients, and then they get that sort of active process going in their brain, and they actually feel good about coming to treatment, and it's sort of fun and light and feels good versus some of the other therapies which they often feel like either can't follow because they're struggling cognitively, don't make a lot of sense because like their cognition is not working, or it just feels kind of like a drag. So contingency management can be like very positive. The idea is that it's extremely reinforcing and that you can target certain behaviors, whether you're targeting sobriety or attendance. You can motivate people to engage in certain activities. The drawback is there's a little bit of pushback sometimes from providers who feel like, should we really be rewarding people for doing what like they're supposed to do, or coming to treatment? Should they get paid if there's money involved with the reward for coming to treatment? Like that can feel distasteful to some folks, and so talking that through is really important if you're on a treatment team, that everybody be on board, because if people have reservations about that, they're going to struggle. And then there is some organization. So if you have to buy gift cards, you have to track these things in order to provide the reward. There's some administrative kind of organization that is required that can be, a little bit burdensome on providers. So in general, this is, behavioral reinforcement. The way that it works is the patient attends or engages in whatever behavior you want them to. You give them the incentive as immediately as possible following the behavior. And then the goal is, and what the research shows is the patient reduces substance use and is retained in treatment longer. You are all probably very familiar with cognitive behavioral therapy. And so that is another evidence-based treatment for the treatment of stimulant use disorder in both pregnant women as well as other people. And so this is, oh, I'm sorry, this is not CBT, this is the continuation. I thought I had reduced my slides. So this is more contingency management. So the idea of just frequently monitoring the target behavior and then providing the incentive very quickly to get the person in the habit of engaging in the desired behavior. Another treatment is community reinforcement approach. And so this is actually a combination, it always feels to me like a combination of multiple different interventions. It incorporates some contingency management, some motivational enhancement. It can also involve like recreational activities. So it's kind of a complicated, very comprehensive approach that I encourage people to read a little bit more about. So the components include the basic skills training that we might find in CBT, as well as recreational counseling, job counseling, relapse prevention, and motivational interviewing. And some programs also include this voucher-based reinforcement, which is basically like contingency management. And then CBT, I jumped ahead to CBT. So you guys are all familiar with CBT. The idea is to teach, encourage, and support individuals on how to reduce their use, take a look at some of their patterns and how to interrupt those patterns, whether they be behavioral patterns or cognitive patterns that lead to substance use. It's not an insight-oriented treatment. It's behavioral and cognitive. And these are some of the key concepts, which you guys are probably familiar with. And I'll actually go over this 3-component model of emotions with patients, and I usually frame it as an incredibly positive thing. So you have this emotion, let's say an emotion that's a trigger for substance use. So for pregnant women, the emotion might be guilt over using during pregnancy. And so the person can intervene to change that emotion in a variety of different ways. You can change your behavior, you can change your thinking, or you can change sort of what you're doing physically, because every emotion has a physical component. And if you change how you feel physically, that often leads to emotional change. So like 3 ways to change your emotion that will actually help support recovery and sobriety. The matrix model is another one, and this is a evidence-based treatment. Then the manual and the client's treatment manual are available to be downloaded on off the SAMHSA website. So that's really easy way to like just have access to this treatment. Again, similar to some other comprehensive treatments. This one includes some family education groups, which the other ones did not include, and specifically encouraging and using 12-step recovery as part of the training. So if you take a look at the treatment, they use some 12-step recovery concepts in the treatment model. And then just a quick overview of some of the other approaches that have some evidence, but not as robust evidence as the 4 we just talked about. So physical exercise is kind of drawing more and more research and evidence as a specific treatment for methamphetamine use, again, because of that dopamine and reward connection. And this particular study that Rick Rawson did, he was also one of the researchers for the matrix model, found that there was reduction in depression and anxiety, as well as reduction in relapse among those who engaged in this exercise treatment. They did also find that it worked a little bit better with people who had less severe disease. And then mindfulness meditation as a treatment for methamphetamine use disorder has also been studied and shown to be effective with those who have co-occurring mental health diagnoses. And it also helps with methamphetamine abstinence. And any of these can be used with pregnant women. Pregnant women typically would need to get maybe doctor's approval before engaging in exercise, but it's moderate exercise. It's not like go out and run 5 miles. It's like moderate exercise several times a week. And then motivational interviewing, which is not really an intervention, as you saw, as a component of some of the other interventions, but has been shown to have a positive impact with those who have methamphetamine use disorder or stimulant use disorder. And these are some of the core skills of motivational interviewing, which many people do as part of many different therapeutic interventions. Motivational interviewing is sort of a specific way of talking about problems and talking about decreasing use or talking about substance use disorders in general. As I mentioned before, there are no FDA-approved medications for stimulant use disorder in pregnancy or postpartum or at any point for people who are not pregnant. And there have been a lot of medications that have been studied. These have not been studied in pregnancy, but just a list of some of the medications that are kind of under study currently that have shown some results that are positive, some kind of mixed results. We certainly do prescribe Remeron to patients, and always important to consult with the OB before prescribing any medication to make sure they are in support of that. But Remeron can help with sleep and depression among our pregnant women who have stimulant use disorder. And then just in summary, so vital to stabilize psychotic symptoms, especially if there's any concern with violence. So often patients presenting with either intoxication or even like acute withdrawal can be very, very agitated, and that's often best done in an inpatient setting. Referring to evidence-based behavioral interventions, providing prenatal care is also key with pregnant women, obviously. We know that there's an association with engaging in substance use treatment and adherence with prenatal care. They kind of go hand in hand. And so for those of you who are lucky enough to be involved in clinics where those services are either co-located or it's actually the OB or family practice provider who's also prescribing, that is absolutely ideal when it's possible to have the same person providing prenatal care as also is prescribing any medication, or the provider who is engaged in the behavioral treatment. And then treating psychiatric comorbidity, again, in consultation with the OB to make sure medication management is approved for pregnancy. And I always end with the most important thing being instilling hope. So for those of you who have involvement with the ACE program, I think the ACE program and have a peer recovery support specialist. Peer recovery coaches can be masters of instilling hope because they are, living, breathing examples that people get well. And so whenever we can have a recovery coach associated with programs working with pregnant women, I think that is invaluable. And I feel very lucky to have that in our own program at WVU. And these are just some resources. So specific to CBT for substance use disorder, there are apps, and also there's a specific website called cbt4cbt.com that have a lot of resources you can check out, and patients can certainly check out that can be helpful in treating substance use disorders. And then just a little bit of mention of the research on stimulant use disorders as well that I mentioned earlier. All right, so I'm working on sticking to my time frame, which will make Jay happy, and I think that's it.
Thank you so much, Laura. You did great as usual. So thank you for sticking on time. But we have time for questions, so we'll open it up. If anybody has any questions, please feel free to unmute and ask away. I will say, to get us started, Tanya put in the chat about there's some decent YouTube videos on the Matrix. So maybe to look out for those as well. So thank you, Tanya, for dropping that in the chat. Very helpful. Anybody else? The floor is open.
So I didn't mention specifically, but I usually always mention when working with pregnant women with substance use disorders, and it's whether they have a methamphetamine or stimulant use disorder or not, just being very attuned to that guilt and shame that can sometimes look like something else, like anger and irritability. But in fact, most pregnant women who come to us have had to go through a tremendous amount just to get in our door. And so sometimes they are very sensitive to any kind of judgment because they're judging themselves so harshly. So just something to be aware of. And with stimulant use disorder, people are often very dysregulated with regard to emotions, So treading lightly, and being compassionate and supportive, obviously. So I saw something come through the chat.
Yes. So let's see. It just popped down here. It says, is there any evidence supporting the use of Suboxone as a medication in MAT for stimulant use disorder, given that fentanyl is often mixed with meth?
So that buprenorphine is under study. It does not have robust evidence, but it is under study. And you're exactly right. So oftentimes people will say they're using methamphetamines, and then when we do urine drug screens, there's fentanyl in there. And so trying to figure out if they have a dependency on fentanyl, like if that's a regular use issue, or if it was just like a one-time incident. But we often find that people are really struggling with both opioid use disorder and stimulant use disorder, even though they may sort of not know it. Obviously, we know that the symptoms of withdrawal are fairly different, so it can be teased out in that way. But so yes, if someone really has both, you would treat the opioid use disorder with buprenorphine if that is what the patient would like, and certainly that's what the evidence supports, and it's safe to do in pregnancy.
I'll just kind of tag in a little bit anecdotally. When we've had patients that have both amphetamine use disorder as well as opioid use disorder, we do sometimes have to modify their treatment plan to include more of that contingency management, because the Suboxone or Subutex is helpful for stabilization, but there's still that sometimes anhedonia and impulsivity that comes from that chronic methamphetamine use.
Absolutely. Thanks, Jen.
Hi, Laura. Hi, Pete Yotsuk. How are you?
Good.
Long time no see.
Yeah.
Hey, question about the withdrawal from the stimulant, which has been quite a debate for a long time, whether those cocaine and amphetamine, methamphetamine, really gonna make the baby withdrawal, particularly right immediately postnatal, because many of these moms, as we know, that they smoke, they have some other substance, and many of these stimulants, what happened in the babies or in the newborn is the effect of leftover effect of the stimulant, more so than the withdrawal itself. But at the same time, if they've been exposure since the early on during the whole pregnancy, one would expect that they're gonna some change in the neuron, in the receptor in the brain also. So again, I just want to hear from Dr. Price and you also, what do you think about the withdrawal or the true withdrawal for the stimulant in the newborn?
So good to see you, Pete. And so specifically in the baby, thank you for adding that. So certainly you're going to see it fairly quickly, because you're going to see it in the first couple of days, and babies are often highly irritable, difficulty soothing. I'm not a neonatologist, so this probably is not my area of expertise. If other people have more experience in treating stimulant withdrawal in newborns, and any kind of comfort measures that they're given.
Yeah, we kind of like, as I said, that we don't have any specific pharmacological treatment for this kind of baby, right? We just do whatever non-pharmacological treatment. And as I said, that in terms of withdrawal itself, most of the time, many would describe it as, in the textbook, they would describe it as, it's just the stimulant itself that left over and has effect on the baby, as you just described. So again, I just you know, in term of withdrawal itself, I do believe that, you know, that some brain or some receptor will be upregulate, downregulate. We're just not sure whether they withdraw or they just has been upregulate that way. Like it's gonna be, you know, permanent, long term or not.
Yeah, I mean, sorry, go ahead.
I was just going to say that's something I can definitely check in with Dr. Hansen, and maybe we can kind of report back next session. I will say it's definitely thrown a wrench in things for us in our health system because of the, you know, the way that the amphetamines can clear from the UDS if the mom hasn't been in treatment. It may not be something that the team is looking for at delivery. And sometimes those babies can get discharged before we really have done anything for them. And so we have gotten a couple of kids kind of caught in the peds side of things as having some, what we would normally label as withdrawal symptoms in an opioid exposed newborn. So it's kind of a new thing for us too.
Jennifer, thank you for that answer. That's a great reminder that Dr. Hansen is actually up to present at the next session. So he can, hopefully he can bring that answer and then do the other presentation. So maybe that'll work out. Any other questions before we switch gears to the case? All right, hearing none, we'll switch gears. Thank you, Laura, so much again for presenting. If you do have a question that pops in your head, please put it in the chat. We'll get to it after the case as always, but Jennifer Price is going to be presenting a case today. Jennifer, I'll share my screen and I can scroll it for you. You can just walk through it. As a reminder to everybody who maybe are new to ECHO, so the case is de-identified. We're just going to run through it. It's not going to take that long. It's not supposed to be something super in-depth that would take, 15, 20 minutes. This is more of a 5 to 7 minute presentation with asking for basically some next steps or advice what you would do in the near future. And so we'll open it up for comments and clarifying questions. And we will take some brief notes down for Jennifer that will go back just to Jennifer since it's her case, but that's typically how the case discussions work. So I will go ahead and share my screen and I will then turn it over to you, Jennifer.
Okay, so this case isn't particularly illustrative of this month's topic, but this is one that my team and I are really struggling with. So I do hope to get some feedback from everyone. So this is a client who has been pursuing recovery for the last approximately 2 years. So she entered our health system around 28. She is currently 30. Prior to her most recent pregnancy, she was incarcerated, which is how she started her process of recovery. She was incarcerated on drug-related charges, of course, detoxed in jail. It's around 18 months old, I believe now. After that, I'm not sure whether the baby was born in jail or right after she was released, but around the same time, she enrolled in an outpatient MAT program, was on Suboxone 4 milligrams twice a day. However, while in the outpatient MAT program, became pregnant again within 2 months after having her first child. She was really quick to get into prenatal care, which was great. She was in prenatal care within 7 weeks, and her OBGYN referred her to the MARC program, not only for MAT, but also so that she could be followed by the high-risk obstetricians. And that transition was made by the time she was about 15 weeks along with the youngest child. She had been compliant with the MARC program. Her attendance was good. She was going to her all of her prenatal appointments, which is a requirement for Mark, going to support groups outside of the group therapy, began working with a peer recovery support specialist. So in general, everything that we would have asked her to do, she was doing. And at that time had a toddler and was pregnant and was doing all of these things we were asking her to do. She decided that the baby that she was pregnant with and subsequently delivered, that child, she was going to allow a family member to adopt because she was not in a position in her life to take care of 2 children under the age of 2, both financially and just in terms of trying to rebuild her life after many years of substance use disorder. The baby was born a bit early with a premature rupture of membrane. Baby was around 36 weeks, no other complications. There was a mandatory CPS report, although mother was, had been compliant in treatment, but because she tested positive for a controlled substance at the hospital, they were required to make that CPS report. The baby was then discharged directly to the family member who is pursuing adoption. Our patient graduated from the MARC program and successfully transferred over to MOMS, the postpartum program over on the Cabell side of things. Once she was there, there was a domestic incident with the baby's father. He's the father of both children. He ended up tearing up their entire apartment. They got kicked out of that apartment. So mother and toddler went to a domestic violence shelter. After that incident, when CPS became aware of it, they removed the toddler from her at the shelter and initiated further child welfare proceedings on that older child. The mother is highly motivated to regain custody of the toddler. She is a little bit ambivalent about continuing to go through with the adoption, I think mostly just because of the emotional stress of being separated from her child that she has a bond with. CPS has given conflicting directives to her and to our staff. So this is not just kind of the patient misreporting. They've been confusing with us as well. For example, they wanted the patient to go to inpatient treatment. She's nowhere near qualifying for inpatient because she's been sober and doing well for a long time. Our PRSS who has been working with the patient, really her primary support has been with ROIs, with releases in place, has been kind of an advocate with her CPS worker. And CPS will not give our staff or the client a straight answer about whether she should go to sober living or wait for a public housing arrangement. So they've said she just needs housing and she can have her kid back. But will not respond to inquiries about is sober living appropriate to have the kid back or not. And in addition, with the patient's emotional state, she's growing ambivalent about adoption. We also discovered that the partner who the DV incident happened with, and also he was in active addiction at the time of the incident at the apartment. He has not given his consent for the adoption. The mother and the partner are separated, but they do have ongoing contact, which in my experience could be also a problem for CPS. As far as comorbidities, she does have major depressive disorder. Her most recent prenatal screening, PPD screening rather, was a 11, and the cutoff's 11. History of unspecified anxiety, restless leg syndrome, tobacco use disorder, and has a history of stimulant use disorder, but none while in our programs. So here's kind of where we get to the sticky part. So she'd been doing so well. And then in the past 2 screens, before she was converted to Suboxone, we found naloxone in her urine. So she was taking Suboxone when she was still prescribed Subutex, which led treatment team to believe that possibly she was sharing her prescription with her partner because he is now an outpatient MAT, so he would have been prescribed Suboxone. She admits to doing this one time, but there were 2 weeks in a row where this pattern was found. And it's unknown how much she's really admitted to her prescriber. Her prescriber's over on the Cabell side. but this is what she's told her PRSS. So our main appeal to the team is just how to prioritize all of these issues. She has a lot going on. We know she has it in her to abstain and to use her medication responsibly. We've seen her do it for long periods of time, but she just has so much going on at once. How can we prioritize these things to help her the best?
Awesome. Thank you, Jennifer. Great job. Just stop share real quick so I can see everybody here. So are there any clarifying questions or comments before we go into some of the recommendations? Anybody have any?
Yeah, quick question.
Sure.
Yeah. So do you guys test for buprenorphine and norbuprenorphine levels, or is it just for naloxone and buprenorphine? Can you separate that out? Because that'll help you decide if she's diverting or not. Because I guess that would be the concern. You know, diversion's one issue on top of everything else, obviously.
Sure. So we do think she's typically using her medication, but there may have been a time where she and her partner were both using back and forth the same prescriptions. So, but we do check for their the metabolites.
Okay. Yeah, because I would be less concerned. I mean, honestly, people get themselves, you guys know this, they all come in on Suboxone already, although Subutex has a higher street value. So, you know, there is that possibility. So.
Thanks, Dr. Valtierra. Any other questions? All right, so what would be some next steps? Let's try to give a couple of recommendations here for Jennifer. Who would like to start us off?
Is it safe to say that contingency management therapy has not been tried or has been tried and was unsuccessful with her?
So she's been in MAT for close to 2 years now, I believe. I don't know whether she's had that in the past when she was primary amphetamine use. The program.
Yes.
Where in addition to the MAT, they get tickets for things that they're required to do for treatment, such as coming to group. And those tickets, they can then later exchange for, they have kind of baby items and things like that.
Thank you, Hillary, for the question.
So the answer is yes, she was in that, or no. I'm not quite clear if there was a yes or no answer.
Sorry, I'm gonna turn my video off. I just saw that my audio broke out a little bit. So the program that she is currently in does have an element of contingency management. It's also MAT, so they have traditional individual, group, and cognitive behavior therapy and medication, but there is a contingency management element to it as well.
Awesome. Thank you so much.
So, Jennifer, I'm just wondering, with her current drug screens that you say could possibly be misuse of MOUD medication, would that, and I don't know how far out that was, but would that not be something that could be looked into to start that inpatient process to maybe get some more stabilization in there?
I think that's an option. In our kind of health systems, the places we would be likely to refer to her, if she did not acknowledge anything beyond using a medication very similar to a medication that she's prescribed, if she still would admit to that happening one time and no use of illicit substances, she would not likely be given high priority on a wait list in our area.
I was wondering if her care could be escalated to a little bit more intensive. Here in our MAT program, when we have situations like that, we may put our patients into more of like an IOP type setting until we could get things sorted out.
Yes, I like that idea. Can I ask, like, what type of content would they receive usually if they are coming to the clinic more frequently?
So our so for our IOP people, so if you have somebody who's attending weekly and they relapse and use methamphetamine, and their care would be escalated to an IOP program twice a week, and we would see them on Mondays and Fridays, where they would receive, they would participate, of course, in their med group and their behavioral health group, and we might increase their individual therapy at that time. If it's a benzodiazepine relapse, they are seen then 3 times a week. If they're in a higher level of services, like it, or not higher, but if they're only coming like bi-weekly, we would drop them down to weekly. And if it was continued, then they would go to the IOP. So it's not as punitive, but it's just a, more escalated care for that person. Did that answer your question?
Yes, that makes sense. We typically do that as well. I think I was more along the lines of thinking, say she does have maybe an extra therapy session, for example, what would people...
Jennifer, you went out again. If you can hear us.
I can hear you. Can you hear me now?
Yeah, we can hear you now. Just go ahead and start over again.
Sure.
Yeah.
So yes, that's what Tanya was describing is really, that's consistent with what we try to do, is just to increase the amount of contact we have with the patient when something like this happens. I was wondering, like, in terms of therapy targets, what are people most concerned about? The potential misuse, or she did admit at least one incident of misuse, or housing, relationship? What's striking people?
I know for me, I'll say, Jen, when I have a couple very similar cases, and I know for me, and I know this is based off of everybody's hypothesis of where they need to go in treatment. So it definitely would vary, but I like how you asked the question, like, where would you look? And I know for me, my area goes towards the relationship, because I had one very similar case, and she was pretty stable in her recovery, but it was the relationship that she was addicted to and continued to get into that prevented her from moving forward with getting her children. And so we worked on that piece as she sustained her recovery. And so for me, that's where I would hypothesize, but that's just my direction.
Hillary agrees with you. She put in the chat relationship as well. So you 2 for that.
Although I think that's sometimes tough there, because we find so many of our couples that we treat together, the relationship and their addiction can be a lot of the issue. And unfortunately, they always aren't beneficial to each other. But if she's not housed anywhere, I think that's a big issue as well. So, I mean, we're a small program, and so often we treat both partners, and that can be brings up some interesting ethics and conflicts. If I'm treating both of them, oftentimes I can usually get 2 therapists, but I'm usually just the only one prescribing for them, so it gets a little sticky, especially if the relationship is contributing to it, especially from the male partner, which is usually what we see.
I would think that would be very tough. And I think especially in this area, that's one of the barriers we come across, right, is access to care and having enough care to be able to treat both effectively.
Right.
So coming from a background with homelessness, and of course, here in Charleston, we see a lot of homelessness within our patients or unstable housing. I would, of course, ask her and try to prioritize with her what she sees as her highest priority and what she sees as her needs. But starting with the housing and the supportive housing, and I'm wondering about like working with Harmony House there in Huntington and having a SPDAT done and all that to see if she qualifies for any type of like SOAR housing or supportive housing programs.
Very good. We're about 3 minutes out. Are there any other questions or comments? Great discussion, though. See, we got something in the chat here. Hold on a second. Let's see. Even with stable housing, if the harmful relationship is not addressed, her risks are still increased. She will find stability in that unhealthy relationship wherever she is housed. Thank you for that.
And I just wanted to mention, so my dream is that we can work with CPS as a team. My experience is not always that. So I know Amanda and I are going to be working on trying to reach the dream, at least locally, to really improve our relationship with Child Protective Services, because often I feel like we are asking women to do so much, and we're asking and they're asking, and sometimes we're asking them to do things at the same time, and they can't do two things at the same time. And my hope is that we can develop a better partnership with Child Protective Services.
Yes, that's definitely something that we're working on right now with Cabell County also. It's just every once in a while you just get a case where, and it's not always Cabell County, sometimes it's folks who are, their case is originating from another county.
Jennifer, we lost you again.
Oh, I'm
So
sorry.
You said it wasn't only, the last thing we heard was Cabell County, but then also from other counties.
Yeah, yes. So you're kind of at the mercy of the individual worker who was assigned the case. So we are working on kind of improving our relationships as systems, but we're kind of at the beginning of that process. So I really appreciate all the feedback. This was wonderful. So I hope other people will submit a case next month and we can do this again.
Great segue, Dr. Price. Thank you so much for presenting. We really appreciate it. Yes, cases, please submit cases. They, like we were saying before, they do not need to be, very complicated. Get to right what do you want to know, right? The questions and things like that. So please feel free to submit cases. And we also have an evaluation that Lynn, thank you for putting that in the chat. It'll also be in the recap email that'll be sent out after the session. And our next session will be on March 14th. And Dr. Zach Hansen is scheduled to present on cannabis. So we'll be diving into that. All right. And more emails to follow as far as reminders. I know it's a month away, so things get lost in the weeds. So we'll be contacting everybody. But we appreciate everybody joining, and we'll see you in a month.
Bye, everyone.
Bye-bye.